How are you doing today?
Hi, Deanna. How are you?
Good. Thank you so much for taking some time to sit down with us and have a discussion about a recent publication that we're really excited to learn more about. I'm sure the community is very familiar with you, but if you wouldn't mind just giving a quick introduction to yourself.
Sure. Thanks for having me to talk about this recent project. My name is Eli Diamond, and I am a neurologist and neuro-oncologist at Memorial Sloan Kettering Cancer Center in New York. I treat adult patients with all different histiocytic disorders, and I've run several clinical trials in this area in the last few years.
Amazing. And you do a lot of tremendous work, and we're really grateful for you. And I know the community is really grateful for you as well. So, you have a publication that you wanted to share with us today. Why don't you give us the title of the publication and where it's been published?
Sure. So the title of the publication is Mixed Histiocytic Neoplasms, a multi-center series revealing diverse somatic mutations and responses to targeted therapy. And it was published in the British Journal of Hematology. And I'll just say that it was written by um, a large group of authors from many institutions, including MSK, the Mayo Clinic, University of Alabama, Birmingham, um, uh, Israel, Israeli colleagues, and then some others as well. So a really multi-center, multinational collaboration.
Exciting. It's amazing to see all the collaboration across histiocytosis, and especially considering that we're so rare. Knowing that you all are working together is really encouraging and uplifting. So, give us a little bit of background as to what led you to do this study, and then I'd love to hear a little bit about what significant findings came out of the work, and really kind of overall what the publication is detailing.
So the background is that in in the years that I've been treating patients with histiocytic neoplasms like Erdheim-Chester disease or Langerhans cell histiocytosis or Rosai-Dorfman, over the years, I've had patients who ended up having not one disease but two at the same time, and then either the two diseases coexisting, or one before the other, or in some sort of reverse order. And then there are some patients who have, let's say, Erdheim-Chester disease in bone and Langerhans in the skin, or they may even have both diseases within the same biopsy. I found this a really fascinating manifestation of the disease, and we've just become increasingly curious over time about what is there anything unique and special about this particular form of histiocytosis, and is there anything we can learn by sort of getting lots of different centers together to pool their experience and learn about it. We're not the first to make this observation and to write about it. The the disease that is the mixture of ECD and LCH, that's been described many, many, many times. And particularly, our French colleagues wrote a paper about this a number of years ago. And they pretty much, in their experience, patients with both ECD and LCH had the BRAF mutation. Period. It was an entity that was pretty much defined by having the BRAF V600 mutation. And then on the other hand, the French group and ours a number of years later, we talked about patients with ECD and Rosai-Dorfman at the same time. And in that series, most of the patients had their mutation not in BRAF, but a gene called MAP2K1. And so this idea kind of, I don't want to say set in, but has become sort of the prevailing idea that ECD-LCH has a BRAF mutation, ECD Rosai-Dorfman has a MAP2K1 mutation, and in my sort of experience along the way, I did not think that that was the case. I had seen patients with ECD-LCH with other mutations and vice versa, and so we wanted to sort of get as many cases together and see if we can really describe more of this spectrum, and then also, my informal experience had been is that, if there's sort of some treatments that are more used for LCH, such as chemotherapy, and some treatments that are more used for ECD, say targeted therapy, my experience had been that if people have both, if you give them more the LCH type therapy, the chemo type therapy, it doesn't work as well. And patients like that need targeted therapy. And that was kind of a hunch, but I wanted to put some numbers on that and see if that really played out.
Well, I really appreciate your passion for looking into this, and our experience in talking to the community, there have been quite a few people that we've spoken to who have had LCH or ECD or Rosa Dorfman has been very difficult to treat, and then later on down the line discover that they potentially have more than one histiocytic disorder. So it's been a learning opportunity, I think, for all of us to explore this further. So what were some of the things that you uncovered as you started to explore this more deeply?
Some of the main themes were that the ECD LCH mixed form does have a predominance of the BRAF mutation. However, we found other mutations in patients with this as well, including MAP2K1, other BRAF mutations, and then even something called a BRAF fusion. And then in the ECD Rosai Dorfman combination, we did see the frequent MAP2K1, which has been observed in the past, but we saw other mutations such as a gene called KRAS, which has been found in ECD and in Rosai Dorfman, but not in the mixture previously. We did even have one patient with a mixture of Rosai Dorfman and LCH, which is a fairly uncommon observation. We saw that there were some patients who had the diseases separated into different parts of the body, but a number had them sort of mixed under the same slide. I would say from a treatment standpoint, the main observation is that what I call conventional therapies, such as chemotherapy, immune suppression, was almost never lastingly effective for these patients, whereas the targeted therapies like BRAF and MEK inhibitors were quite effective. And I don't think the fact that the BRAF and MEK inhibitors worked is news. That I think we know from experience with the other diseases, with the single types. But the fact that if you have someone with ECD and LCH at the same time, you really need to treat the ECD as the lowest common denominator. I think that's new information, although I think it's been people's experience all along.
Really helpful guidance to understand where to approach the therapy, maybe from the gate, once you can uncover that there are more than one histiocytic disorder involved. But it also sounds like this should be something that providers should be considering, to explore whether or not, are there certain scenarios where someone might suspect that there's a likelihood of mixed histiocytic disorder?
Yeah, so I think that's really the point, is that if you have someone who has LCH and it's just not responding in any way. One thing is that there's LCH that responds and then it comes back later. But if you have, LCH that's kind of just trucking through, you have to think to yourself, does this person maybe have ECD also? And, in our experience and in the other published experience, they don't necessarily present at the same time. Someone may have LCH first, and then upon reevaluation, when things like chemotherapy don't work, you will then see some evidence of ECD. It raises to awareness that even people treating LCH, it's helpful to have some familiarity of some of the features that are more unique to ECD, and to have a sort of to have that kind of in the catalog of possibilities as a reason for LCH or Rosa Dorfman not responding in a way that it may otherwise.
It's really interesting. And I think over the years, we've learned that there's a lot more commonality or overlap between these histiocytic disorders than we originally thought. And so, to your point, having some awareness and education around all of them can be incredibly helpful, just to know what to look for or to understand the signs and symptoms. So, this is really important to the work that you're doing. And do you see future implications or additional areas of exploration? Like, what impact do you think this will have?
Yeah, so I would like to think that from just from a clinical standpoint, there's a little bit more of an awareness of this mixed or overlap form of disease, and that it should provide an impulse to lean towards targeted therapy. One thing that we were not able to do is do the mutation testing for all patients in both diseases. So, it is true that we inferred that the mutation is in both. We did not actually demonstrate that it's in both. Insofar as there are still some unanswered questions about what is the exact blood cell subtype that becomes LCH, that becomes ECD, and what's different between the two, what is there to learn from someone who has both in terms of where in the blood cell family tree um, the gene mistake, the gene mutation happens. And so I think that patients like this, if we know how to look and where to look, I think they may provide an opportunity for some of this sort of lineage, family tree type research.
It's very exciting. I know we've come a really long way, and there's still more to learn. So it's exciting to think that we can potentially use this as an opportunity to dig deeper, and to better understand all of the histiocytic disorders in addition to this mixed histiocytosis. Um, Anything else you think is important for either the patient family community or your colleagues to consider or think about in relation to this topic?
No, I think it's the awareness that the mutations are not limited to what has previously been described. To keep the possibility in mind, and to not have high expectations from chemotherapy in this context.
Well, thank you so much for diving deeper with us on this publication. I had a chance to read it, and it's amazing. The work you're doing is incredible, and so I encourage everyone listening in to also read the publication and learn more about the work you're doing. And we look forward to continuing to follow up with you on future projects and maybe even more in this area as well.
Thank you. Thanks for highlighting the paper. I appreciate it.
Absolutely. Thank you so much. Have a great day.
Thanks, you too.